Hey, I'm Andy, and I started Harry's, the shaving company that's fixing shaving. Here's why some of our customers choose Harry's.
The blades are about $2 each.
I get a nice, clean shave every time.
The blades stay sharp for plenty of shaves.
Thanks, guys. And for everyone else, give us a try with this special offer. Get a Harry starter set with a 5-blade razor, weighted handle, shave gel, and a travel cover. All for just $3 plus free shipping. Just go to harrys.com and enter EASY at checkout. That's harrys.com, code EASY.
Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, here again with Dr. Millicent Ravello. Millicent, what's going on?
Not a whole lot. Hanging out with you, doing our podcast.
Ready to talk about revision rhinoplasty?
Always.
This is a huge topic.
It is. It's a long one.
Well, it doesn't have to be, but I think it's going to be.
It might be, yeah. But it's good. It's a big topic, and we got to tackle it, so let's do it.
Well, diving right in, revision rhinoplasty is when you've already had a rhinoplasty. You've had some kind of nasal operation to improve the look of your nose, or the airway, I guess, could be part of it, and you're not happy, and you need more surgery to fix it.
Right. So you've either, like you said, had the surgery before for cosmetic reasons or for airway obstruction, and something about it is still not quite right. And it can range, right? It could be a functional thing because you can't breathe, or you might just not like how it looks, or both.
Or both. And, and there are people that have first-time revisions, second-time revisions, third-time revisions. Other terms that people use is secondary rhinoplasty or tertiary rhinoplasty. I use the term heptenary rhinoplasty at this time, which would be 7.
What is your highest number of revision?
14.
Oh.
I think that's a Tertiary
rhinoplasty. 14's a hefty amount.
It's a lot. And it was a guy that really, his nose was demolished. And he should not have been having more surgery per se, except that his breathing was so bad and the look was so bad. And there were answers to make it better, which we did. But I think the key to understand with revision rhinoplasty is that you have to have clear-cut goals for what you're trying to achieve. And the communication between surgeon and patient is essential to getting through this.
Well, I think that's true for all rhinoplasties, but for sure when you're coming in with a revision rhinoplasty, because there are a lot of obstacles and you have to be organized about which ones you can realistically address and fix and which ones are way down on that list of things that you can address.
So I see a lot of patients for this. It's probably, 50% of my practice is revision rhinoplasty, and probably 35% is primary rhinoplasty, and then the other stuff fits in the other 15%. But the revisions that I do are often for problems that I think could have been avoided at the primary rhinoplasty. The first most common thing in my practice is what I call the completion revision rhinoplasty, where you're kind of finishing off the primary. It's just that things didn't get done enough. They didn't get the hump down enough. They didn't get enough definition at the tip. They didn't shorten it enough. And by the way, that happens to me too in primary rhinoplasty, where one of my most common reasons to revise a rhinoplasty is I didn't shorten the nose enough and rotate it enough. I'm so paranoid of creating a pig nose that I would rather have to trim a little bit more off the septum and not deal with it looking piggy, because lengthening is a whole different animal, right?
It's easier to make it a little bit shorter than to try and make it longer and flatter. Yeah.
And that definitely falls into the completion rhinoplasty category. I also see the underdone hump, where you just haven't taken it down enough. Now, I don't want ski slopes, but at the same time, people want to get rid of the hump.
Right, that's what they went in for. They want the hump done. Yeah.
They want it smaller. I very rarely have seen a patient who's like, I really want my nose a lot bigger. Have you ever seen that?
No, I can't say that I have.
What about in the world of revisions for you? If you have to pick how you're going to get it done, what's one of the cartilage sources? Because a lot of times these people have have lost their septum, right?
Right. Usually at the first primary rhinoplasty, someone's taken their septum.
Or worked on it.
Or worked on, done something to it. So that middle part, the cartilage that's in the middle of your nose that separates the two halves, that's your septum. And that's frequently harvested or something's been done to it at the time of the first rhinoplasty. And so that is typically a source of grafts that you use in the nose for support and to open it up or to restructure it. And so when that's gone, you have to look for other sources of cartilage to rebuild the nose.
Right. So this is really key because in secondary rhinoplasty, you've only got a few choices left if the septum's gone.
Right.
What's your favorite choice of cartilage? I know mine.
Well, okay, full disclosure, I did all my rhinoplasty training with you, so I think we know the answer there.
Very proud of that.
Yes.
We're rib people.
We're going to go for the rib. So the other choice is the ear. But I think when you're looking at a revision patient who really needs a whole takedown and redo of their nose and really rebuilding it, the ear is not going to be sufficient.
Why do you say that, Dr. Ravello?
Because it's not going to have the support and the rigidity or the quantity that you really need to get that graft setup that you need to basically rebuild the nose. Because when you're doing a revision rhino, and I've seen you do it, and this is how you do it, you basically take it apart. If it's a true revision that needs to be redone, some of the noses will just need a little tweak here and there and call it a revision. But you're really revising a nose. You almost have to take it apart and then put it back together.
I've just found, and yes, full disclosure, I did teach you to go for the rib because, I mean, there's a reason why people don't. And I understand that. It's another donor site. It's far away from the nose. With the ear, it's right there. You can kind of turn the head and you've got some ear cartilage. Yeah. But what I found, and this is why it really swayed me. So back in the day when I was learning what my preferences really were, like around 2005 and 6, when I really got into revisions pretty heavily, which is a long time ago, I thought I was doing my patients a favor by using the ear cartilage. I'd be like, yeah, we're going to use the ear. Don't worry about it. I can totally redo it. I can cut the grafts from there. And I would use ear cartilage for all these like major league grafts. And what I found is that if the skin was thick and that the scar tissue was strong, that the ear cartilage is just, feel your ear. No. It's soft. It's nice. It's squishy.
It's bendable.
It's squishy. To quote Fat Bastard from Austin Powers. But
that's not what you want.
It's not what you want in a nose. No. You need something that's going to hold shape.
Yeah.
If you feel the rib, listen. That's me pounding on my ribs. And if you can understand that that's going to be much stronger, that's where you go. Because the grafts that you can cut, and we're not talking about big blocks of rib that's put on the dorsum, which some people do. We don't do that. Like that's not, I haven't done a big block rib graft since I was a resident in Pittsburgh at the VA in my first year of residency, of plastics residency. That was the last one I put in. And by the way, I'm going to show that case during my presidential address at the Rhinoplasty Society meeting in Las Vegas. But for us, we want strong grafts that are going to hold shape. Right. You can't beat the scar tissue with ear cartilage.
No, and that's the whole thing. So let's talk a little bit about these revision rhinos, because we've talked about why they might come in. But then when the patients come to you, what is the most common thing that they want you to do? Or do you have a most common, or is it a grab bag?
Well, it depends on the problem, of course. But, the most common thing that I hear from the patients is that it isn't what they wanted. It's a well, I got this. And it's not like it's a disaster. I mean, the disasters are the disasters. Mm-hmm. We do see them. But that's not like most people who go to get rhinoplasty these days are going to people that do rhinoplasty. People get on the internet. They do their research. They see how many before and afters you have on your website. So I think most patients who are, just a little bit insightful will wind up in the office of somebody who does rhinoplasty. Right. But then they just say like, well, it's just not what I wanted. I wanted something better. I wanted something different. And they'll point at things. And so that's why I say let's just say that I can only fix 3 things. What are those 3 things that you want done? And that really helps direct the patient into understanding, oh, he only said 3 things. because I had a list here of like 46. And actually, the longest list I ever had was 21.
That's still a substantial list.
I mean, you can't get it all. Like, it's just not going to happen.
Yeah.
So the list, by the way, is a little bit of a warning sign because, when the list has 21 things on it, like, it's not going to happen. You're going to have an unhappy patient.
Right.
So I always listen carefully, and I make sure that, this is a patient I can satisfy because, a lot of people, it's hard. They aren't going to be satisfied no matter what. And so why should they spend a ton of money, ton of time, go through surgery, and still not be satisfied? And we can identify those people. I mean, don't you agree?
No, it's definitely pretty obvious when someone comes in for the first time, the second time, the third time, and they have the unreasonable expectations. And you can tell, who you can help, who you can make a difference in, and who's going to be happy with that change versus some patients will just always find something a little bit off. And I think it's pretty easy to pinpoint those patients ahead of time.
Well, one thing that you said is the first time, second time, third time. Once they hit the third time, it is a bona fide fact that a patient that needs 3 separate consults will not be happy with the result of the rhinoplasty. That is a studied and published set of data that once they've come for the third consult, not the pre-op appointment, they can come once, they can come twice. But when they hit the third, I'm still trying to figure out if I should do this, then you should tell them you shouldn't.
Right.
Because they're not going to be happy. And that's not, it's just, it's a fact. Like, we have that study. And so why waste their time, their money, and take them down a surgical path when it's not going to make them happy?
It's not what they necessarily want.
Yeah. I mean, it is, there's a lot. I mean, I always say that rhinoplasty, nasal surgery, is identity surgery. People have their identity
Is
on how
their
they look,
nose, yeah.
and their nose is right in the middle of their face. So if you're going to do this work, you want to stack the cards in the favor of your patient. You want to do the right thing for them. And so when you see things like that, like, hey, this is our third consult, I got to tell you, and I do. I say, look, you're here for your third consult. We're not doing surgery, number one, but number two, like, there's a study that shows that you're not going to be happy, and I'm not here to tell you to do surgery or not to do surgery. But, in my experience and based on the information I have, don't sign up.
Yeah. I think that's very wise. I think that is a wise thing to do and hard.
Well, you got to tell people no.
Yeah, it's hard to do. So you have these patients and they're coming in and now they're ready and they're signing up. And we talked a little bit about the rib graft. What percentage of your revision rhinoplasties are you using rib in?
I don't know the percentage of I would say it's probably half of my revisions, maybe more. If they need grafts, I'm using rib. But a lot of times there are cases where I'm adjusting things, changing, scraping things out, moving things, moving grafts. So it's not necessarily so that I have to have rib cartilage in every single revision rhinoplasty.
Just if they need grafts and more
If they need grafts, I'm doing it. And by the way, there are some patients where they didn't touch the septum. So if they went to a plastic surgeon and they had a straight septum, they may not have had their septum taken.
Right. It might still be there.
Yeah, it might be there. And that does happen fairly frequently. So it just depends. But I use rib when I'm looking at structural issues. I'm a rib guy.
So what is different that you tell the patients between what they can expect from their first primary rhinoplasty to their second or third? I mean, obviously they've gone through this before. They sort of have an idea of what to expect because they've done it. What is different now, the second time or the third time that they're going back?
Well, I tell them it's a completely different operation. Primary rhinoplasty and revision rhinoplasty are 2 different things. I can't say it any clearer than that. Let me try. Primary rhinoplasty and revision rhinoplasty are 2 different things.
You're saying they're 2 different things.
They are 2 very different things. There is no way to look at them as the same operation. And that's so important to get because people think, well, I've had this. I did this before. It wasn't so bad.
Yeah.
Wrong answer. It is bad. It is a totally different thing. Well, it's not bad. It's just that it's different and you have to be ready for it. The healing time is prolonged. If you need rib, you have a new donor site that hurts.
Yeah.
It does. It's
rib
not
sore.
nothing.
Yeah.
You have swelling that's worse than your primary.
Way worse.
We're going to need a separate podcast about swelling because
Call it It's Swelling.